Welcome everyone to our program today called Telehealth, 3 Practice Perspectives. It's my pleasure to be one of the MCs for this presentation, along with Mitzi Young, who is the RCMA, CMA physician advocate. I'd like to turn it over to Mitzi, and she'll tell you a little bit about our program today.
Thank you, Dr. Bittman. Thank you, everybody, for joining us today. We know that in our new way of doing business, telehealth has been booming. It's been struggling a little bit through practices that we hear. So we really feel it's important that we reach out to everybody, kind of help folks navigate this world of telehealth and balance that in-person and telehealth aspect of their practices. We have 3 physician panelists today, and we're very excited to have them and get their perspectives on telehealth and what they're doing in their practices and the successes that they're having, and perhaps even the challenges that can help you overcome some that you're having in your practice. So I want to introduce our presenters today. Obviously, Dr. Barry Bittman is going to MC today. Dr. Mahdi graduated from Sofia Medical Academy in Sofia, Bulgaria, and completed his residency at the University of Louisville Hospital, specializing in primary care. He is board certified in Board of Family Medicine and the American Board of Hospice and Palliative Medicine. He is the chair of the Inland Empire Palliative Care Coalition and the Coalition's advisory group. His affiliations include assistant clinical professor at Loma Linda School of Medicine, and he is a fellow of the American Academy of Family Medicine. Dr. Mahdi is also past president of the Riverside County Medical Association. Thank you, Dr. Mahdi, for joining us. Dr. Jacobson, pediatrician and chief medical informatics officer at Children's Primary Care Medical Group, maintains dual board certifications in pediatrics and medical informatics. Champions the medical group's informatics and innovative initiatives, including telehealth, patient communication tools, the electronic health record, and data analytics. Thank you, Dr. Jacobson. Dr. Feinberg attended Tufts University School of Medicine, surgery internship, San Diego Naval Hospital, battalion surgeon, Seabees, Okinawa, otolaryngology head and neck surgery residency, Oakland Naval Hospital, chief otolaryngology, Long Beach Naval Hospital. He's been in private practice in Riverside since 1990. Thank you so much, all of you, for joining us today. I will turn this over to Dr. Bittman.
Thank you so much, Mitzi. It's a pleasure to be able to provide this program for us today. What we're really focused on is the ongoing use of telehealth in our nation. During prior webinars, I'm sure many of you have attended, we've really covered a host of telehealth considerations. We've looked at the utilization, workflows, challenges, billings, regulation, and the rollout of telehealth during the national health emergency. This webinar, however, is different. What we decided to do today is to really try to harness the perspective of 3 highly respected practitioners, people who are in the field who are using telehealth on a regular basis. Our goal today is to help you optimize the care of those you're privileged to serve by learning from these experts, these subject matter experts, on the benefits and the utilization of telehealth in their practices. I'm not going to spend a lot of time on the slide. However, we have seen tremendous growth in the use of telehealth in the United States due to the NHE. We've also seen that regulatory changes have evolved to enable us to be able to use telehealth for both primary care and specialty medicine. The regulations have undergone several revisions, and there is a tremendous push to continue those telehealth regulations beyond the national health emergency. In fact, today in California, it was basically announced that the continuation of telehealth would be supported by the government in a manner that would enable practices to continue utilizing the service. On the other hand, we're also noting that in some areas, in some pockets around the country, the use of telehealth is falling. And we found in speaking with many physicians that they felt that the reimbursement would not be the same under telehealth, despite the fact that the payers, for the most part, the health plans, have joined together and have agreed to support this. Our format today is really to tap into the intelligence, the high-level insights of three highly respected physicians who have given us the opportunity to basically speak with them about their knowledge, their experience, and their recommendations for moving forward. We have a number of questions. Our answers are going to be limited in time. And at the end, if we have an extra few minutes, we'll take some questions from our panel. So allow me to begin by thanking our doctors Mahdi, Jacobson, and Feinberg, and especially Dolores Green of RCMA, who has made all of this possible. With that, let's begin with a basic question. Let's start with Dr. Jacobson. Can you provide a concise overview of your practice? Tell us a little bit about your practice and perhaps how you've used or how you are using telehealth.
Absolutely. First of all, thank you for having me and thank you for the nice introduction. I hope that my comments live up to it. As you mentioned, I'm a pediatrician located in Carlsbad. I'm the Chief Medical Informatics Officer of Children's Primary Care Medical Group, CPCMG. We have offices from the border with Mexico all the way up into Riverside. And about a year ago, we combined forces with Pediatric Partners, Dr. Moore, his practice, and so we have a large presence now in Riverside. We take care of about 275,000 pediatric patients. We are primary care pediatrics only, part of the integrated delivery network with Rady Children's Hospital and on their instance of Epic.
Thank you so much. What a phenomenal introduction. Dr. Feinberg, you're next.
Good morning, good afternoon. Can you hear me?
Absolutely, you're coming through perfectly.
Fabulous. It's been quite a challenge this morning finding a laptop to do it because our computer system went down in the office. My practice is general otolaryngology, head and neck surgery in private practice here in Riverside. I'm blessed with an associate who just matriculated a year and a half ago from Cleveland. And we have a practice that is essentially one of the busiest practices in Riverside. We average prior to COVID over 600 to 700 patients a month that we see in the office, including about 50 to 70 surgeries that we do that are elective. We have a practice that's primarily based 60 to probably 65% would be managed Medi-Cal, with IHP being the 800-pound gorilla with that. And the primary reason is we signed up for that years ago because we have a strong interest in pediatric ENT. And so far, we have been blessed in regards to the majority of our staff have stayed with us since COVID, and we're still able to provide some very good care.
Thank you, Dr. Feinberg. And finally, last but not least, Dr. Mahdi, tell us a little bit about your practice and the integrated services that you provide.
Thank you, Dr. Bittman. Our practice is a small group practice where we're 9 providers in our group. We have 5 family physicians, 1 pediatrician and 3 nurse practitioners. And we also have 3 RNs. The reason I bring the RNs in is because they've been instrumental in our transition here. We see about 20,000 patients a year. We probably see about 40% managed care Medi-Cal through IHP, and then we have our rest is through our prime care affiliation for our commercial and seniors. We are a patient-centered medical home, NCQS certified level 3. We're on our 3rd recert, and we've transitioned over to telehealth, and we'll be happy to share any of our experiences with you all.
Thank you so much, Dr. Mahdi. Our next question is really focused on looking back over the course of the last 6 or 7 months, and perhaps sharing with us some of the major challenges that you might have experienced when you started using telehealth. Let's start with Dr. Jacobson.
Thank you. Well, I have to say that we had started using telehealth before the pandemic, and we're fortunate to be part of a large network. And so with Rady's assistance, we have the technical parts of it figured out. I think once the pandemic hit, some of the big challenges were letting patients know that we were available by telehealth, and educating related to the quality of a telehealth visit related to or compared to an in-office visit, that a lot of the things that we do can be done via telehealth. I think the other big challenge was just getting all the physicians and mid-level practitioners trained and onboarded. There are some intricacies with webside manner that are just different than in-person interactions and bedside manner. So just kind of getting everyone comfortable and trained with it. So those were probably the two biggest challenges.
And do you feel that you're over the hump with those issues at this
Absolutely. Prior to COVID, we had just a trickle of video visits. And as soon as COVID hit, within a couple of weeks of very, very significant effort by our fantastic IT and management team, along with training of all of the physicians, we've got 100% buy-in from the doctors and other practitioners in the group, and patients are very much appreciating the service. So I do feel like we've overcome those.
Thank you. Go to Dr. Mahdi next. What have been your experiences when you started using telehealth? And perhaps you can share some insights not only from your patients, but also from your staff.
Absolutely. I mean, we were actually in the process of transitioning to telehealth before the pandemic started. In December, we were looking into transitioning to utilizing telehealth. A reason was we realized that probably about 80% of visits we saw in office could have been managed very easily by an RN or a nurse practitioner, and really didn't require to visit in the office. So obviously with the coronavirus pandemic starting up, we transitioned right away to our telehealth. And obviously there were some challenges since this came on pretty sudden. One of our biggest challenges, I would say, was trying to get patients comfortable with the process and trying to differentiate between a phone call from me, for instance, following up on some labs versus calling them as a visit. And it was a challenge at the beginning. And one of the things we realized was we had to maintain a schedule timeline, just as if they were in the office, so that if a patient had a 9 o'clock appointment, we are trying to stay within 10 minutes of that appointment. And this way the patients feel comfortable with it. Anecdotally, I will tell you some funny things happened. One of our visits was, I called a patient up and she was in the market shopping. And so those were some of our challenges initially because they didn't feel this as a visit. One of the things I want to share is we wanted to measure our success going forward, and we did some surveys on our patients, and we had 3 questions. Was this telephone appointment as good as a face-to-face? Would you schedule a telehealth appointment again in the future? And then free response. And we had about 271 responses in the last 3 months, which was pretty good. 96% was very satisfied with the program. And some of the comments was, I don't see why we should come to the office again. Some of the nice things about this telehealth is it freed up our in-office visits so that we can, for instance, bring in more of our pediatric child exams, for instance. And we had more time to get some of our quality metrics going forward.
Thank you so much, Dr. Mahdi. Let's turn it over to Dr. Feinberg for a second. You know, you're in a slightly different situation because you're a specialist. And I've been looking forward to learning your perspectives on this, especially in the context of how your patients and referring physicians reacted to telehealth in your practice.
Very similar experiences to what Dr. Mahdi described, and in some ways that Dr. Jacobson described. The first and the most challenging aspect was eased by the fact that we had already progressed over the last year and a half, or really a year and a half prior to our pandemic, with electronic health records. Without having a great EHR system that's specifically designed for the specialty that we're in, we would not be able to do the care we can do, and I feel we do it very well in telemedicine. The issues that first hit us was, first of all, getting me up to speed with telemedicine. My associate being younger, and he was an engineer for 10 years. He and my staff educated me. And once we started doing it, the patients became, I think, very appreciative of what we were able to provide. As a specialist and in my field, we have a challenge at times that the patients will come to see us and we'll say, it's great seeing you, it's great to examine you, great to meet you, but we need to do some studies that we can't do here in our office. A lot of them may be laboratory studies, a lot of them may be radiologic studies, that once we have now with telemedicine that they call us and they have a specific issue, we can at that time state, we can order this for you, we can order that for you. Sometimes the primaries are not allowed to order it. They can only be ordered by the specialists with certain plans, such as sleep studies or specialized radiological studies, CAT scans of the temporal bone, navigational control of the sinus, MRIs of the inner ear. And by having the knowledge and being able to speak with the patient, get their history, go over it, we can do these studies before the patient even comes to our office. And that way we can help determine how soon they need to come to our office for our examinations, or whether or not their care is so complex that we may need to refer them off to a tertiary care center at a university that's close by, either Loma Linda or UCI, based on their problems. And the patients seem to be very appreciative of this, not having to make I see patients from Barstow to Hemet. So some patients are traveling over an hour to see me. That being said, then they have to wait in the office for a half hour, sometimes unfortunately longer. With the use of telemedicine, we've been able to ease these time issues and get the care with the patients based on the workup their primary has already done, what we can do with telemedicine before they see us in the office, so we can make a good decision as to whether or not they need to continue medical treatment, be referred to other specialists, or will need surgical treatment. So it's been nice. The challenges, though, we have about only a 65% hit rate in comparison to what we were seeing before. Despite patients getting text messages, emails from our system, and at times phone calls from our staff that they have an appointment coming up, we have about a 30 to 35% where we do not reach the patient. And then we hoped that based on our messages that we leave, that they do call back so we can take care of them or their children. And to allude to what Dr. Mahdi's saying, they're quite often, with patients traveling so far to see me and waiting in my busy office, despite how efficient we are, with telemedicine, we can go over a CAT scan result. We can go over a laboratory test. We can go over an MRI test. We could do that on the phone, and it could take 15 minutes to do it. And the patient's very appreciative, where otherwise they would have spent half a day with their doctor's appointment, with travel, waiting time, doctor's visits, and plans afterwards. And I think this can be very effective in the future, God be willing, post-COVID, for specific patients that we can use telemedicine and still provide effective care for them.
Thank you so much. I think the insights that you shared from a specialist perspective are extraordinarily important to all of us. So thank you all for sharing that. I'm going to go back to Dr. Jacobson now, and basically in looking back, and I think, the retrospectoscope is a wonderful tool. If you could replay those months, how would you describe the value of telehealth in your practice, not only for caring for your patients in general, but for making it through the COVID national health emergency, which obviously we're still facing?
Yeah, and unfortunately, we probably have a good year left. I think the value for us has been immense. I really can't understate how important it's been. I think the care that we provide, as primary care pediatricians, a lot of what we're doing is hand-holding, reassuring parents that are nervous, that have children, with relatively minor illnesses or concerns. And so we're able to do that just as effectively via video visit. A lot of what we're also seeing, also pre-COVID, but unfortunately more now, are behavioral health concerns and mental health concerns. And so almost all of those, if not 100% of those, can be taken care of by telehealth. And in fact, we found that a lot of those visits are actually more productive by telehealth because patients and their families are in their home environment. We're able to see some of the social determinants of health that are going on in their environment because they're at home and there's whatever is going on in the background. And it's actually a lot of times more helpful than having them come into the office. So I think that's the value for us. I think the value for the patient, is just as high. Both because they don't have to travel, they don't have to potentially be exposed to germs in the waiting room, let alone, potentially to the coronavirus. And so I think the value to them has been immense. And then, obviously we can't ignore, the financial impact that the pandemic has had on all of us, and being able to continue to provide care that is both warranted and desired and needed by our families, and again, high quality, but also getting paid for it, I think has provided a tremendous value.
Thank you. Those are transformational insights. I'm going to ask Dr. Mahdi to chime in. Do you agree? Have you seen the same in your practice? Or your experiences similar?
Absolutely. I mean, it's really has transformed the way we approach taking care of patients. I would say patients prefer it tremendously to be seen at home. It's more convenient. As a result of our telehealth transition, we actually even started our psychiatry telehealth through our office. Contracted with a psychiatrist since the psychosocial determinants has been pretty high requirements, and that has been very, very successful. Result of our transition to telehealth, we've actually even started our RN triage, and we're actually adding a second schedule for the RN triage, since the majority of calls coming in can easily be handled by RNs, and we are there for their backup. So it's been a really very, very positive input for all of us. And the most important thing, I think, is making sure that the quality of care is still being maintained, which is always could be a challenge, and the patient satisfaction. As we know, patient satisfaction is paramount to healthcare. Doesn't matter how good we provide the care, if patients are not satisfied, we get a poor score. And I will tell you that some of the comments coming out of our surveys were amazing. One patient says, continue with phone appointments. It was better than in-person appointments. And I think the phone call or the video call with the patient at home in their own environment puts them at ease and allows them to probably express more of the things that's on their mind versus in the office where it always seemed to be in a rush. We were always trying to get the patients in and out.
Well, I'll tell you, with your survey, Dr. Mahdi, you've certainly hit it out of the ballpark. 96% is extraordinary in just about any aspect of healthcare. Dr. Feinberg, coming back to what you said before about 35% no-shows, I was really taken back by that because of the fact that most physicians tell me that telehealth is far more efficient. In the context of this, could you, one, reflect on what changes you've made, and two, could you speak for a moment about the value of keeping a specialist going during the COVID national health emergency, given the challenges that you faced?
Thank you. I'll try to address both of them. The challenges that we faced, basically, I feel, is based on our practice milieu of 60 to 65% managed Medi-Cal. We have situations where we're trying to contact patients, yet we have patients who have multiple other challenges in their daily lives as a result of COVID. And despite the efforts that are made and the desire from both sides to have a contact, it just cannot be achieved. Either the mother has something else to do or forgot about it, another child has this issue, another child has another issue, or the manner of the fact that we fortunately, all my office staff, except for me, are bilingual. I can understand Spanish very well, but at times I do not have the capability to fully convey to a patient what I feel needs to be done. We sometimes are not able to achieve the full telemedicine appointment until I have one of my staff either translate with me right then and there, or even one of the family members themselves to translate. In regards to being a specialist and the challenges, it goes outside of telemedicine. We in ENT have the highest incidence of getting the COVID infection. They've lost about 30 ENTs in the world so far to COVID. And we had to stop doing surgery except for emergency and cancer cases. And with all due respect, with every time we try to set up a surgical procedure with the laboratories, because of the saturation of testing that they're doing, they could not get the testing back to us for 4 to 5 days. And we can't trust that mom won't let little Billy go play with the neighbors for 5 days, nor can we trust the adults as well. So we can't bring patients to surgery when we're operating the nasopharynx and oropharynx, where the virus lives in the belly of the beast there, and put the anesthesiologist and the OR staff at risk without testing that can come back in 24 to 48 hours. So without the PPP loan, we would have been done. There's no question about it. Without the help from our foundation and Dolores with her capabilities and talking with IHP and IHP Direct and the team there, specifically with their CEO and their other solid people, the help that we got from global payments that were provided for specialists based on what we were able to provide them from 2019. So without the PPP loan and without the global help for these payments that were based on what you and I and our whole team in the foundation discussed at our meeting that we had, that you brought up to us, Barry, that what's going on, I believe right now in the Maryland area. Was it Maryland or is it?
It's Maryland.
Blocking? Yeah,
You're
where
correct.
they have had global payments. Without those two financial assistance packages, we would not be talking right now. They have kept us afloat. Now, because of Abbott coming out with a one-day test or a 15-minute test that's similar to almost like a pregnancy test, and the fact that we've been told that the Quest laboratories can get the testing back in 48 hours, we can finally, as of this month in September, start scheduling elective surgeries. And our patients with telemedicine and everything else, when we communicate with them about that, they're very happy that we can get back to our surgical practice. So telemedicine has been great in keeping a certain portion of our practice afloat. And without it, and without the insurance companies covering it, which brings up another specter, the sword of Damocles, we wouldn't be afloat. And that is a fear that we have that we discussed, and I'm not sure what we can do about that with organized medicine as to post-COVID, whether or not we can continue with telemedicine, because it is a tremendous benefit for many of our patients' care, as we've all discussed already.
Thanks for sharing lots of words of wisdom. We have a phenomenal level of respect for everything that IEHP has done, and working with Dolores has really changed the overall landscape of healthcare during this national health emergency. Dr. Jacobson, when we look back and then compare our experiences to where we are now, in the context of treating people remotely, just quickly, have there been any surprises?
I think yes and no. I think as my colleagues have shared, the satisfaction, patient satisfaction is through the roof. Patients universally seem to appreciate and think that these visits, as do we, are very high quality. And so I think, before having a large volume of telemedicine, before COVID, I would have been surprised to think that that the satisfaction would be that high, not only with the quality of the visit, but with the outcome or the value that the patient perceived that they were getting from the visit. So I think, there are some aspects of, if you look back and you think about, what the alternative was, then it's not a surprise that it's been so successful. But I think the high patient satisfaction and the high quality that we believe we are providing, I think is in retrospect a bit of a surprise. I think for me the biggest is, as within anything that we do, change is difficult. And for a lot of the doctors that I work with, a lot of the doctors in our group, there were a lot of naysayers, a lot of concerns among our group, rightfully so, about how these visits would occur and what the quality would be and what the value would be. And so I've been very, very happily surprised and thankful for really the entire medical group and all of the doctors that I work with have just really come on board. And I think that prior to this pandemic and prior to what we've all experienced, I would have been surprised at the minimal effort that was required for such a massive change. Change is very difficult for all of us, and it seemed to be really just not a problem.
Well, you were a thought leader, and I think when the person at the top steps up to the plate, people listen. So thank you for your leadership in this.
Thank you.
Dr. Mahdi, I'm going to ask you a bit of a challenging question. Over the course of the last few weeks, CMS has been working on their visit codes and their weighting of the codes. We're not talking about in a capitated environment, we're talking about fee for service. And what they've done is they've actually diminished the focus on the history and the physical examination in terms of determining the intensity of the visit. And this, to some extent, I think has followed a bit of contemporary medicine, where the person that you see 4 or 5 times a year perhaps does not need a complete examination or a complete history, but we really have to focus on strategy and outcomes and what we need to do to change behavior. Does the lack of being able to do the physical exam during the telehealth visit impact a significant number of your cases? Or do you find that it really has minimal effect for most patients at this time?
Well, let me say, obviously the challenges, is we cannot do all visits by telehealth. And I think it's a learning curve going forward, what type of visits need to be in office and which ones can be done by telehealth. And that's something we're all learning as we go forward and trying to make sure we schedule appropriately the type of visits appropriately. Examples are, dermatology, very convenient video visits. Patients with chest pains, not a good telehealth visit. Definitely, we need them in the office. We need to listen to their heart, EKGs. It's difficult to do that. So that's been a challenge. Do we need reform in payment reform? I agree. I think we need to simplify the way we bill. But we're mostly a capitated environment. So for us, this has worked very well for us.
Thank you very much. Dr. Feinberg, surprises? Have there been any?
Surprises? Yes. I'm surprised that it's worked so well for the patients that we're able to take care of. And I'm surprised that they have been so appreciative. The other surprise is the fact that I thought we would get in a fee-for-service environment that we are predominantly in, 7% or less of my practice is capitated, that we would get a big pushback from the PPOs in regards to timely reimbursement. And based, I think, and correct me if I'm wrong, the efforts that have been made by our medical associations and our national, the insurance companies have been kowtowed by this and have paid us promptly and appropriately. That's a surprise. I thought we'd be fighting this for, it takes 45 to 90 days to get paid anyway. I thought we'd be fighting this for 5 to 6 months after telehealth visits, and we're not. So I'm very pleased about that. In regards to determining who needs to be seen in the office, we have found that obviously we cannot debride an ear in a diabetic patient with otomycosis over the phone. So we've decided that my associate and I would have separate days every other week where we just have ear days and bring in our ear patients. Our patients that need scopes, for our cancer patients, for our nasal polyp patients, we bring them in and we have specific days for that we just have those patients coming in. And it's made it easier on our practice that we have dedicated days specifically for dedicated patient pathology that we could take care of in the office, and we identify that way. And it may be a way we change our practice in the future, that we have these identified days just for these patients that our office staff can key up for and prepare for. The other surprise I alluded to before is how willingly our patients have accepted telemedicine and are happy with it. And I think that is based on our modern times with people used to electronics, people used to using these devices, but we have had some challenges in patients, a lot of them saying they do not want to have video conferencing. They feel somewhat invaded on in their privacy, and that they don't want to see their environment that they live in. They don't want to see them. They want their kids to be specifically all dressed up when they come to the office and to be clean and neat, and they just do not want to have me doing the examination via video conference at their home. And we document that, but I still feel we can do effective telemedicine. For patients that I call and they say their child has a cyst in their mouth, I say, hey, mom, take out your phone, send me a picture, send it to the email. And we look at it. We could tell how close it is to the vermilion border. We could tell whether or not it can be removed in the office or we're going to need to be under anesthesia. I mean, prior to COVID, I've had numerous nurses and also doctors and doctor spouses text me on the phone and send me a picture of their kids' tonsils. Gary, what do we do about this? It started before. And it's rewarding to have patients be so happy with this, considering everything else going on that we have to deal with.
Thank you. For us, it's nice to be able to get some great news at a time like this. And maybe this is the silver lining in this entire crisis. Maybe this truly is a transformational moment for healthcare. I think we've really covered this question, so I'm going to moved past it. This is a real concern to me at this time. I think that one of the real issues is that, as I mentioned earlier, many practices are thinking about moving back to in-person visits. And I personally think that that's probably not in the best interest of people we serve. I'm going to start with Dr. Jacobson. You're responsible for a very large population of children. What are your thoughts from a population health perspective in terms of continuing telehealth?
Well, I think I appreciate the question. I think we're all in on telehealth. There's no question that a certain percentage of the visits that we perform, primarily the preventive visits, the well child care, it's really important for us to do those in the office. And certainly currently and until this the COVID pandemic is over, we have, as I'm sure everyone on the call does, significant modifications in place to make sure that the in-person visits are safe. So for those preventive visits, unquestionably, and a proportion of the non-preventive visits, those will continue to be in person. But to get to your question, I think there's no question that we're all in, and we will continue not only at the current volume of telehealth visits, but we will continue to push the limits on what we can do by telehealth. I think, again, because so much of what we do really does not require examination techniques that have to be done in person. And this goes back to one of your other questions previously about the exam. I think, honestly, 90% of the examination for what we do in primary care pediatrics, at least, can be done with a good quality video call. Obviously, we can't auscultate the heart or the lungs. We can't look in the ears. And so there are certainly some limitations, but a very good neurologic examination, a behavioral examination, a psychiatric examination, and certainly even just the common bread and butter upper respiratory infection. We have the parent take the child's shirt off. We can see if they're tachypnic. We can see if they're retracting, if they're parent, in any distress, and certainly divert those to in-office visits. And so I do think that a significant portion of the exams that we typically do in office can be accomplished by a good video call. So we will continue to pursue telehealth to the maximal benefit of our patients and the practice.
Thank you. Same question for Dr. Mahdi. Do you see this as a strategy that will continue well into the future and change the course of healthcare, or do you see this as a temporary means for getting patients in, with practitioners moving back to what they were doing previously?
No, I mean, as I stated initially back in December for the COVID-19 outbreak, we were actually preparing to transition to a telehealth model. It's much more efficient. I think, like Dr. Jacobson said, 80–90% of what we see in the office really can be done by video telehealth visit. What it's done is changed the roles of a lot of our staff, and change is difficult. As we all know, an office visit takes a lot of time out of the staff, from a scheduler, from a reception greeter, to a medical assistant checking them in, to a medical assistant checking them out. That's all gone away. And really what we've done is, a lot of the staff initially were worried about their jobs. And really what's happened is we've reassigned them in doing more quality care and pushing us more for pay for performance. Since that's the future of, I think, healthcare, and we all struggle with that with our limited staff ability. Now we have more staff available to help with quality measures. So I don't see this going away at all. I think this is going to be more the standard.
Thank you, Dr. Mahdi. And Dr. Feinberg, I have a tough question for you.
Okay.
About 6 years ago, I had the opportunity to lead a conference where we did telelaryngoscopy with the Cleveland Clinic remotely about 1,500 miles away. And we were doing this on a performer in the music industry. And it was extraordinarily beneficial. But 5 years ago, 6 years ago, telehealth was really not in vogue. Where do you see us moving in the context of the future in terms of expanding telehealth into testing, into procedures, into bringing experts into the care of individuals where the patient might not have gotten that service previously?
I think this is a springboard for many, many other different ways that we can take care of patients in the future, many different ways that we can get tertiary care evaluations based on the capability of the equipment that we have in specialist offices. It would be wonderful for me to be able to do a video stroboscopy of a patient here in the office and get the opinion with that without the patient having to be seen by the team at University of California, Irvine, by Dr. Crumley or by Dr. Krishna over at Loma Linda, that they have that video stroboscopy already there for them to visualize and see. This is something that, as we said, that Dr. Mahdi, had the prescience and the understanding to start doing telemedicine before this pandemic. This is something that I feel that can continue to broaden our capability to get diagnostic studies, tertiary opinions, specialist opinions, similar to what has happened with the use of just the simple devices, which aren't so simple, but are phones. As I told you before, it's already started with parents and nurses and doctors sending me pictures of their kids on the phone. I can't see why that can expand to the future for other specialized procedures that we do in the office, in a specialist office, as well as the capability to also video share it with the primary who did the referral, and if necessary, with the patient, with their desire. I mean, I can't tell you how many times I've asked a patient to look up on YouTube if they want to see what surgery I'm doing and explain to them the surgery that I am doing so they can get an understanding and have further questions for me. Getting back to something that is a specter of concern in regards to this question, recent studies have documented practices backing off. I'd like to find out what those practices are, because I can't see backing off in any way. That would be my decision to back off, because I feel it's an effective way to take care of patients, and specific patients that we've already discussed, to review labs, CAT scans, other studies that we do, sleep studies, to go over further testing or procedures that may need to be done. But I fear that we may not have a choice in this, that Medicare or the PPOs or a combination of them will finally say enough is enough and rely on the altruistic nature of the physicians that we are, that we will call a patient back and say, hey, your liver enzyme tests were high and you need to go see this doctor about it. Or, hey, I'm worried about your CAT scan and I need you to come back and see me, but these are the things that we need to do. The insurance companies will say, we don't want to pay for this anymore. The insurance companies would rather keep their money in their bank collecting interest rather than put it out to a telehealth call from a doctor, when they know that the doctor is morally and ethically responsible to let the patients know about their test results and guide them with it. In the past, we did this without getting financial reimbursement. And I fear that without the efforts of organized medicine to keep telehealth in the nature that it is and have the private insurance companies and have Medicare reimburse, we may have it taken away from us in the future, and therefore our patients.
Well, I'll tell you, this has been so enlightening. I think if we just took this interview and basically shared it with some of the decision makers at the health plans and at the medical societies, they would realize what the full potential and value of this is. In conclusion, and we're really almost out of time, I'm wondering if you have any final words of wisdom for your colleagues. What would you recommend for somebody or some practice that has really not gotten into it because they were either fearful of the technology or of actually distancing themselves from their patients. Dr. Jacobson.
You know, you probably can assume based on my previous responses, I strongly would encourage anyone who has not already gotten into telehealth to reconsider. It does not take a large investment for a small practice to get into telehealth, because really all you need is a secure FaceTime call. I'm certainly not saying that you should use an iPhone with FaceTime, but there are secure and actually free pieces of software, Doximity, which any physician has free access to. They have an app that is, they report that it's HIPAA secure. Obviously, if you're going to use it, you need to check for yourself. But really requires no investment. It just requires an iPhone or an Android phone, which basically everyone has, to be able to get started. And so I wouldn't be fearful of the cost or the expenditure to get started. I would not be fearful of how patients are going to perceive it, because they all like it. I would strongly encourage anyone who's got any doubts to seriously reconsider.
Well, thank you for your inspirational insights. I turn it over to Dr. Mahdi. Colleague walks up to you and says, you know, I really don't like the idea of distancing myself from my patients and doing this with technology. What would you say to him or her?
Well, probably simply I would say, embrace change. It is your friend. Change is inevitable, and that's how we progress. Healthcare is one of the last bastions that has not changed for the last 60, 70 years. We still have fax machines. And the only reason we have fax machines is physicians can't give it up. We need to change, and we need to embrace change, and it's our friend.
Thank you. Words of wisdom. And finally, Dr. Feinberg, looking into the future, you're at a restaurant, you meet a colleague says, yeah, I thought about it, but it's never going to work with ENT. It's never going to work in my specialty. There's no substitute for touching that patient. What do you say?
I would say I honor him or her for feeling that way, and the feeling of the connection that we have as physicians to laying hands on patients. And based on the time that we would have, I would try to share the experiences that I at first was skeptical or about, and how I found that even though I thought this would only last a few months, and now we're at 6 months, that to try to share with him or her that telemedicine in a specific patient, the patient would be much happier with the telemedicine, that they are not putting themselves at risk, that your staff will be much happier that they are not putting themselves at risk based on the fact that we do examine the ear, nose, and throat area where this virus lives. And that I would also share my experience based on the time that we spent and the fact that I was recalcitrant at first, that I feel it would be an excellent way to practice medicine in the future. If they chose to listen to me thoughtfully and respectfully, they may try it. But some specialists just feel and that it has to be hands-on. And after a certain point, I would explain, yes, after the first few telehealth visits, you have to lay hands on the patient, because you're not going to set up a surgery to remove tonsils in a child without examining the child, meeting the parents, explaining to them the indications and risks and alternatives. You're not going to do a septoplasty without examining the nose based on a CAT scan report. You have to examine them yourselves, and they will get the opportunity to lay hands on the patient once they do the preliminary telehealth workup. And that may convince them. That may.
Thank you. And I'd like to take this opportunity to thank Doctors Jacobson, Feinberg, and Mahdi for sharing some exquisite insights. I have a great deal of respect for all three of you. You are true pioneers, and you're evangelists that can help us move forward as we advance our healthcare system into a new era. With that, I also want to thank Dolores Green and our support from RCMA and certainly IEHP for everything that they do. And in closing, I'm going to turn this back over to Mitzi, and she's going to tell you a little bit about the kinds of resources that we have that can help your practice.
Thank you so much, Dr. Bittman. We actually do have a question in our question box, so I wanted to throw that out there to you guys. And the question is this: are there any ongoing studies or evidence of bad outcomes so far with telehealth that you're aware of? Any physician, any one of you guys can chime in on that one.
I'm not aware of anything.
Dr. Jacobson?
You know, I'm not aware of any specific studies. I'm sure if you went searching for it, you could find someone who claimed that there was a bad outcome, but nothing that I'm aware of.
Okay, Dr. Mahdi?
Yeah, I'm not sure. I've not seen any outcomes or studies on that, so I'm not sure how that would translate.
Okay, and Dr. Feinberg?
Very simply, I get emails every other day from my academy in regards to recent articles and other aspects with my field. I have not seen it, and nor do I feel confident that we're not going to see it in the future. There will be a situation that a misdiagnosis will be made with telehealth. There will be a situation that another study could have been done and a patient has a poor outcome. And I do fear in the next 6 to 12 months, there may be litigation as a result of it. And when I think about that, I also think it's the same risk as seeing the patient in the office. And certain things will happen. So my feeling is nothing now, but I wouldn't be surprised to see something in the future.
Okay, all right. All right, good. So those are really good answers. I think that, you know, in the 6 months that telehealth has been here, certainly as a practice management person, I haven't really seen or heard of any of that thus far. That doesn't mean it's not happened, but I think that it's probably very little. We have another question. So how long are we going to get current reimbursed in telemed from IEHP and or Medi-Cal and or Medicare? And I will answer that question. And I will tell you that the reimbursement will be the same as in person as long as the health pandemic is going, which is obviously we're in it still. It has not stopped. And so for the foreseeable future, we know that you will be getting reimbursements from all insurances, not just the government plans, but the Department of Managed Healthcare just came out with an all plan letter and advising the commercial payers that they must pay the same reimbursement telehealth that they would see in person. So that is some very good news for us. So with, just want to really just quickly go over some of the benefits of membership. It's really, really important that while we're changing, and I love what Dr. Mahdi said, thank you so much for that. And we do need to change and we do need to be open to that change. But one of the greatest things for the members of the Riverside County Medical Association is that we've got a plethora of tools and resources to help you get through those changes. So we've already done all the research, we've got all the material, we've got all the tools and resources to give to you. So don't hesitate to call us. Don't struggle. Don't use Google as your main tool of finding information. Call us. We're here to help you. We want to help you. I am certainly been working a lot with physicians in the telehealth arena. Obviously, employment issues are somewhat of a problem right now with kids in school and doing virtual learning and things like that. So we've got information on every subject that really happens during the day in your work life. So just know that we want you to be here calling us and relying on us and letting us get you the resources and doing the work for you. So work smarter, not harder. Also with the Manifest MedX, I wanted to also give a little information about that because that's the Health Information Exchange. And the Health Information Exchange is really important to be on and be a part of. It's free to join. There are some incentives. I think it's a $10,000 incentive My slide actually is not up right now, so I have to rely on my memory right now. But anyway, it's a great way to know if your patients are coming in and out of the hospital. It's the coordination of care throughout California when your patient travels, and you can know exactly what's going on. You can get your COVID testing results very quickly as being part of the health information exchange. So I think it's something that everybody should take a look at. It's not, again, when people are talking about the financial piece of their business right now, here's another incentive for you all. So you want to make sure that you're giving Jana a call and going over with her the incentives right now available to you. The last slide that we're looking at right now is just really kind of gives you all the resources and additional support with all the emails and phone numbers. So please make sure that everybody in the practice has this. The physicians are not the ones that have to call us. Anybody can call us in the practice as long as the doctor is a member. So if you want to give your staff the ability to do that, we're right here to help. And here's an easy slide that everybody can have. If you have any questions or need any more information, please don't hesitate to give us a call. Thank you so much for joining us today. We really look forward to bringing more webinars and more education your way as things evolve. I want to do a special thank you to Dr. Jacobson, Dr. Mahdi, and Dr. Feinberg. Thank you so much for your time today. We truly appreciate it. Everybody have a beautiful day. Thank you.